Okay, guys. So we are going to talk about elimination. That's our concept for today. If I was there in class, we would review kind of the aspects behind elimination, like what really plays into regulating your elimination, taking in enough fluids, um, eating the right type of fibers, our soluble and our insoluble fibers, um, and just the interventions that we would do when somebody was having issues with it. So let's go ahead and get started. But we're going to review a few things that you may have talked about it in term 2, but we're going to relate it a little bit more to kids because elimination is such a big issue with kids. We'll kind of talk about how it presents in a child and what it really means for them. Okay, so when you talk about elimination, you really also have to talk about fluid intake as well. It definitely contributes to issues with elimination, contributes to constipation especially. And so being able to recognize when you have a child that's hypo or hypervolemic is very important. And you'll see in this chapter they review signs of hyper and hypovolemia and signs of hypo and hyper electrolytes as well. So definitely if you're not comfortable with it, I know it's in term 2 a lot, so make sure you review it in that chapter. It's a really good table that goes over it. Okay, so when we're talking about the distribution of bodily fluids, we're going to talk about the intracellular and the extracellular. And again, this is just a review of basically what is in our interstitial tissues and our extrastitial tissues, right? One of the things with kids is that they are more vulnerable to fluid and electrolyte imbalances. Their body to surface ratio is a little bit different than us. They can actually lose fluid a lot easier than we can. They can become more dehydrated easily. They have a faster metabolic rate. They have little teeny tiny bodies that are still growing and doing a lot more than us adults, our adult bodies are, right? Their kidneys are still very immature, as we've talked about, and so that also changes their ability to metabolize and their ability to maintain their fluid balance as well. So again, this just reviews our intracellular fluid and our extracellular fluid. And it really talks about how sodium is one of the chief electrolytes that determines our extracellular fluid. So whenever you take in more sodium, that's why you have more edema as well, because you have that fluid leaking into the extrastitial tissue. And it's one of the big things that helps regulate our antidiuretic hormone secretion. So, which increases our thirst to kind of help balance that out. Okay. So there are 3 main different types of dehydration. When we have isotonic dehydration, we have low fluid and low electrolytes. They're balanced out though. When we have our hypotonic dehydration, we're lower on electrolytes than we are on fluid. So typically your sodium values would be low, less than 135. When we're hypertonic, we actually have too much of our electrolytes than our fluids. So our sodium values could be very, very high with hypertonic. So all of these can be different values depending on how, if we have like diarrhea or something along those lines, how that was managed. How we replace the fluid would be part of that. So that's one of the reasons why it's really important whenever we have a kiddo that has dehydration or diarrhea that causes dehydration, that we do oral replacement supplement or a balanced parenteral fluid therapy. We want to make sure that we're replacing the proper amount of electrolytes. So you wouldn't want to just do straight water because that's going to be low on electrolytes. You wouldn't want to do, there are certain sometimes I know in the book it talks about how if you were to just give like juices or fluids like that, that can be really high in sugar and high in calories, but not necessarily replacing the electrolytes. So that's why it's important to do like Pedialyte, that kind of thing, instead of kind of coming up with our own way of doing it. It talked about also not doing like broths or anything like that because they can be really high in sodium. A lot of these things we naturally should know by being in the nursing program. You know, that's something that hopefully you guys have kind of learned already, but our patients definitely may not. So it's important to educate them if you have a kiddo that does have diarrhea. So water intoxication can also be a risk. There's more. They typically have this more with infants. They're the most vulnerable population. And part of the reason why is because sometimes they'll have been given formula that was mixed in with too much water. I know we talked about that with Failure to Thrive, that somebody that maybe is low on money and trying to really make their formula last longer will add more water than formula, and that can definitely cause it. And then also your book talked about how infants specifically, they have such immature little systems that they don't quite have the same mechanism that we have, where we know, oh, I've drank too much, I need to stop. They don't have that same like, oh, thirsty, I'm gonna drink, I'm gonna stop sort of mechanism. And so they are just naturally more prone to hypervolemia for that. And then of course they have little baby immature kidneys that also have more difficult time regulating that as well. Okay, so we already talked a little bit about diarrhea. So of course, there are a lot of different viruses that can cause diarrhea. We're familiar with a lot of them: rotavirus, salmonella, I can't say it, but Campylobacter, Yersinia, I can't say that. Shigella, I know norovirus is another one. So there are multiple different viruses out there that can cause GI issues, diarrhea. If you've had kids, you know that is pretty common. And so really it's just teaching the parents to be able to manage it. And one of the things that your book was talking about was how things like the broad diet is actually not recommended with kids because of the fact that it has very low nutritional value, low in protein. All the value from it is not really there. So broad diet is not recommended. They said that they recommend doing oral replacement supplements, so what we were just talking about on the other slide, and then is normal and nutrition filled of a diet as possible. So once they get to that stable period, as soon as they're interested in eating, going ahead and letting them eat and not holding them back to one specific type of food. There's no research that shows that the broad diet is actually beneficial for them, it said. So, and honestly, as a mom, that was a surprise to me, but it talked about how oral replacement therapy is the main treatment, along with just getting them back to eating a nutritional and well-balanced diet. So when we're doing that, like as I said, we want to make sure that we are educating them, and that way it helps manage their fluids and electrolytes. We want to rehydrate them. You remember we talked about what can happen with our pH value. It's metabolic acidosis when you have diarrhea. So that would be a concern. So that would definitely be something that we would want to manage. and education with the parents about like not withholding food and doing oral replacement therapy or supplement would be really, really important. Oral replacement solution, I think it's ORS. But that would be really important. So just making sure that they're educated, and then that they know also those viruses, they can definitely be spread. Making sure you have good hand washing, careful food prep. So if it is like something like salmonella, that we're preventing that as well. And just making sure it doesn't go all the way through the house, because that's what happens. Okay, constipation. So, like I said, I know we're going through a lot of things that, yeah, you guys have talked about before, but it's so specific to kids, and this is honestly a huge issue with children. So, constipation, especially, is a big issue with kids. And we will talk about different conditions that can cause like clinical emergencies when it comes to constipation, like actual structural disorders. So you see that under childhood structural disorders. We're going to go into that in a second. What we're going to talk about right now is just the fact that you might have kids that have functional or environmental constipation. So basically that's idiopathic. We can't figure out what caused it. It might be they're kind of withholding. I don't know if you guys have ever heard the term anal retentive. So that term actually came from Freud, who was trying to do bowel training with children, and the kids that were anal retentive were the kids that refused to poop on the bowel training schedule, like on Freud's schedule. And so they were referred to as anal retentives. That's where that term came from. So it's been around for a long time that kids just don't want to poop when people want them to poop. And will, maybe it's also because of nerves or anxiety or stress that they won't do it. And so it can end up causing more problems. So you see the obstipation. So obstipation is where somebody has been chronically constipated, not necessarily from a structural disorder, from anything else. And then encopresis. So encopresis is very similar, if you've heard of the term enuresis. Enuresis is when somebody is basically incontinent. Encopresis is where you have constipation, but you have fecal leakage. So it can happen when a child gets diagnosed with encopresis. Sometimes that can be because they no longer have the control of the nerves. They can't actually feel when they need to go to the bathroom because they've had chronic constipation for so long. And so that's when you have a child that's maybe just started with withholding that's gotten much, much, much worse. And so with any of these kids, if they have constipation from a functional or environmental cause, from maybe an emotional cause, we want to do bowel training and regular bowel movements with them. So making sure that the parents know to take them to the restroom a certain amount of time, have them try, but also like work with them on their schedule. So sometimes trying to force a child to go to the bathroom constantly can actually make it worse. So kind of working with a kid on coming up with a schedule as well is important. And then doing things like your book talked about how Miralax is definitely very, very beneficial with kids for constipation specifically, and that it can definitely be beneficial because it's so another name for it is the polyethylene glycol. So it is very well tolerated, doesn't really have nearly as many side effects, and it can be mixed with any of their fluids that they want to take, so much easier to get them to take it than a lot of other things. And then of course just making sure that you're increasing their diet, because sometimes their fiber in their diet, because sometimes their diet can definitely cause it. So working with the kid on what works best to get them on a regular bowel movement program. So, okay. and it won't do it. There we go. So, vomiting, I don't really feel like I need to talk too much about this, other than the fact that, again, they can have viral causes of this, and we'll get into when vomiting is going to help us diagnose a structural disorder in a second. So, of course, this is how we measure input and output. I would hope you guys know all of this. I feel like I don't really need to teach it. Okay, Hirschsprung's disease. So now we're getting into some of our more interesting structural disorders. So I'm going to see if I can turn on my little laser pointer. Hey, it's working now. Okay, so my laser pointer, you can see. So Hirschsprung's is where we have our ganglion cells. Normally, or basically, when our fecal matter is going down through our large intestine down to our rectum, our body is able to tell us that we have fecal matter that we need to evacuate from our rectum, right? That's what happens. So in Hirschsprung's disease, they have this absence of the ganglion cells in the colon, and this can cause a very much an inadequate motility of their intestine. So they are not able to evacuate their bowels the way you normally would. You can see it. You have these no ganglion cells area affected by Hirschsprung's. And they can get this congenital megacolon, which is basically like a very dilated, expanded, gigantic colon. It's pretty common in children with Down syndrome. So actually GI issues in general are common with children with Down syndrome, but specifically Hirschsprung's is one of the ones that's more common. And so what do you think you would see with this? So of course you're going to see abdominal distension, discomfort. You also might see bilious vomiting just from the fact that they have this obstruction. So they're not going to be able to easily have a bowel movement. You might have a huge amount of difficulty having a bowel movement, or you might have absolutely no bowel movement. And so you can have a potential for enterocolitis. So of course, if you have this fecal matter that's just existing in the colon like that, we have a high risk for having severe infection within the colon. So that would definitely be concerning. Okay. So typically it can be diagnosed within the first few months of life, you can imagine. I know we had a kid at the hospital who had been able to pass a bowel movement when I think it was a boy, when he was taking in breast milk, but as soon as he switched to solid foods, he wasn't able to have a bowel movement. And so Hirschsprung's disease was one of the things that they were thinking about, because they were like, well, maybe when it was just the fluid that he was intaking, he was able to pass it. Because, breast milk poops are much more leaky. And so then once he had solid foods, he wasn't able to. So Hirschsprung's disease was definitely one of the ones that they were thinking about. So what would you do to diagnose it? So X-ray, but definitely our variant enema studies, because that way we can kind of see how everything looks when it's coming down would help. And so we would want to be able to do that, and it would be diagnosed within the first few months of life, typically. Okay, so I was trying to fix it to where my video head wasn't like right in the way of the picture. But this picture you should be able to see on your slides shows you how they do the pull-through procedure. Essentially, they take off the disease section, the section with no nerve cells, the no ganglion cells section, and then they take the large intestine and the anus and sew them together, is kind of what I gathered from reading about it in the pictures as well. And so that way the child can still continue to have normal, regular bowel movements. But in the initial period, they'd want to do an ostomy until they were able to do that. So that's why it says it's 2 procedures. Okay, so this is one of those things that I'm pretty sure you guys have learned before, but it's important and it's actually way more common in kids than most people would know. So acute appendicitis, in fact, with kids, anytime they come in with abdominal pain, if you are an ER nurse that's really worth your weight, you're going to be thinking as soon as a kid comes in with abdominal pain, do they have an appendicitis? That is one of the things that you should be thinking about. It is very common. One of the reasons why it's common is it's caused by the obstruction of the lumen of the appendix, usually by hardened fecal material, fecalith. So if you think about kids, they don't drink water like they're supposed to, ever. And they really don't like those fibrous foods like veggies. And so they are pretty prone to constipation, like we just talked about. Well, that can definitely be a contributing factor to an acute appendicitis. Other things that can cause acute appendicitis, in your book went on, and I could have put more in there, is infection as well. So it can definitely contribute to it. But you see, I'm going to put on my little laser pointer, our acute appendicitis, our little inflamed appendix at the end of our large colon, and how it talks about one of the diagnostic points is having pain at that McBurney's point. So that's why we have this picture where my big old head's right in front of it, of the McBurney's point. You see the umbilicus right here, and the McBurney's point is just down on that right side. And so what are some of the things that you might see? So they can have significant abdominal pain. And, you know, when I was in nursing school, they always said it was rebound tenderness. That's what they're going to have, rebound tenderness. Well, your book talked about how it's not just only rebound tenderness. Sometimes in nursing assessment, we get like very fixated on something. And I think that one of the reasons why they stopped saying that all the time is because I'm sure there's nurses that were like, oh, that's not rebound tenderness, so I'm sure you don't have an appendicitis. So definitely just recognizing abdominal pain, especially in that region, would be a concern. And then a rigid abdomen. So anytime that you have concern for an appendicitis and then you have pain where it was maybe just in one spot and now the pain has spread throughout the whole abdomen and now they have a rigid, rock hard abdomen, that could mean that your appendix just burst. So it just took it from this is an emergency to, oh my gosh, this is bad, right? So definitely something that you would want to recognize. That's what's important about an appendicitis, is if you're to that point where it might burst, we need to get to the OR stat. So definitely important. I have seen that with some, depending on just how inflamed it is, sometimes they have been able to manage them with just antibiotics and getting it smaller and smaller and smaller before they actually go into the OR. I think there's a lot of just more evidence coming out about how best to manage it. But definitely, if you see a person that's showing signs of acute appendicitis, we want to think to ourselves, are we going to go to the OR still? Okay. So just to review some of the signs, because I feel like it's important. So right lower quadrant abdominal pain, McBurney's point, fever, rigid abdomen. Remember, that could mean that it just burst. Decreased or absent bowel sounds, also really bad, could mean just burst. Vomiting, constipation or diarrhea, anorexia, tachycardia, rapid, shallow breathing. We are talking about a burst appendix and some of this hemorrhaging inside now. Lethargy, irritability, stooped posture. Okay, we just went from like bad to worse. Okay, so the Merkel diverticulum, and again, my big head's right in front of it. So the diverticulum is basically a congenital malformation of the colon, where you have just a little piece of the colon that comes right off of it. And of course, anytime that you have something like that, you can have intestinal obstruction in that area. You can have infection in that area. You can have bleeding. And so it's like a diverticulum, except they're born with this pre-inclination to get a diverticulum, if you know what I mean. Pre-inclination to get that ulceration, bleeding, intestinal obstruction. Okay. So what do you see? And I'm sorry, I changed the color and it jacked up my slide with the Merkel diverticulum. So Merkel diverticulum, you're going to see inflammation and bleeding or intestinal obstruction. So one of the more common clinical presentations is rectal bleeding. When you have rectal bleeding and you have this like bleeding with mucus, you can see current jelly-like stool, and you're going to see that assessment finding and another condition that we're going to talk about. Anytime that we have like mucousy bleeding, you see this current jelly-like stool in the diapers. Not good, not good. Okay, so surgical removal of that diverticulum, and if diagnosed, we can treat it early and they have a full recovery and everything's good to go. Hypertrophic pyloric stenosis. So I think you guys remember a little bit about hypertrophic pyloric stenosis. We briefly talked about it when we talked about our newborn assessment, because it is very important when talking about newborn assessment. And I apologize, I think the slides got jacked up. I'll try to fix them before you guys see this. So the pyloric stenosis, you can see right here, we have a thickened muscle pylorus causing a blockage down in the bottom of our stomach. And what do you end up seeing? You see projectile vomiting. So projectile vomiting is one of the things that you can see. Significant vomiting in general, but when it's projectile, it's always a concern. So these kiddos end up having significant amount of vomiting. And we've actually seen a few at the Pete's Hospital where they've come in and they have had maybe week-long vomiting, and they check them for pyloric stenosis. It's one of the main things that they would look for. Okay. Okay, another one that's really interesting. So intussusception, and you're going to recognize intussusception. You're going to recognize some of the things that we saw when we talked about the Merkel's diverticulum. Why? Because a lot of times they can have intussusception and Merkel diverticulum at the same time. Okay, so what happens is you have this telescoped bowel, which this sounds so weird. So we have to have a picture for it. Of course, my big head's in front of it. But what you can see, if I can kind of explain it to you, normally you have this large intestine that comes down, and the little small intestine is connecting to our large intestine, right? So with our with our intussusception, we have the small intestine kind of going into the large intestine. So the large intestine folds over like this. They say telescopes, but folds over around our small intestine. So hopefully you can see it on the picture on your slides as well. So that is definitely not a good thing, right? So we could have intestinal obstruction in that when we have this area where it folds over, and now you can have fecal matter and everything that can collects into that area, and that can shut off our small intestine's entrance to the large intestine, which would be really bad. Okay, so looking at what do we see with intussusception, right? So acute abdominal pain, vomiting, that red current jelly-like stools, never a good finding, never ever a good finding, right? Because that means blood and mucus. And then a palpable sausage-shaped mass in the right upper quadrant, which is really interesting. So when you have this intussusception, when you have this like folding over of the large intestine of the small intestine, it creates this like enlarged pocket that you can actually feel. So you see on this picture We have our sausage-shaped abdominal masses over here. You can kind of see his like little sausage shape right there. Our red currant jelly-like stools. So this is showing the telescoping of the bowel. It's diagnosed with a contrast enema. And then over here, it also a lot of times happens with intestinal polyps and Merkel's diverticulum, right? So that red currant jelly-like stools, you just have to remember for both of them. So it can resolve in about 10% of patients. Otherwise, it would need surgical management, okay? Okay, so our malrotation and bulbulus. So these are other types of obstructive disorders that you can have where you have a abnormal rotation of the intestine. So depending on where it is, and then depending on how bad it is, where does it also affect the blood supply to the intestine? Really depends on just how it's going to present. So of course, abdominal pain is obvious with this, right? And then abdominal distension because you have an obstructive disorder. And then of course also having that bilious vomiting would also be a sign of this. So really just making sure that we're keeping them NPO until we have a full diagnosis and know the plan for it. Okay, malabsorption syndrome. So we talked about malabsorption issues when we talked about failure to thrive as well. We're only really going to talk a little bit about it. Again, I'm pretty sure that you guys have actually talked about this before, so we're only going to go over a little bit. So celiac disease. So again, I'm pretty sure you guys know about this. You can either have gluten sensitivity is not considered celiac disease. So somebody that's sensitive to gluten that maybe has some GI issues from gluten, not quite the same thing with somebody actually has true celiacs. They have difficulty absorbing nutrition. They can have vitamin deficiencies, especially B vitamins, abdominal distension, significant abdominal distension. Like they might show up with having general malnutrition because of the absorption issue. And then they have the cystinuria, okay? So when they're diagnosing it, the first step they'd want to do is doing a serum test, and that would kind of give them an indication that they may have celiac disease, and then they would follow it up with an upper GI endoscopy to be able to see if there's like any inflammation and everything from it. And so primarily they'd manage it with diet. It does talk about having a low gluten diet because it can be almost impossible to remove all of the gluten protein. Okay, so acute or chronic inflammation of the liver. So we really actually talked about this a little bit when we talked about hepatitis. Typically in kiddos, our viral or hepatitis is one of the main manifestations. So like our hepatitis A, hepatitis B, or hepatitis C. And it also can come on from autoimmune diseases. You can have it from lupus, for example, and then metabolic reasons as well. If we are talking about like metabolizing medications, that can cause hepatotoxicity. And so what would you see? So it depends on what the manifestations of hepatitis are. So of course, jaundice is kind of the thing that everybody knows, right? But also you can have like nausea, vomiting, right upper quadrant pain as well. That's from the inflammation. And then some of the other things that you can see anytime that you have concerns with the liver is like clay-like stools and Coca-Cola colored urine are two of the more classic signs for an issue with your liver as well. And so that would be something that we'd watch out for. And then managing, anybody that's exposed to hepatitis A, B, and C, like we talked about with hepatitis B, they would have to get the the H-big, which is like the immunoglobulins, and the hepatitis B vaccine if it was a baby born to a hepatitis B positive mom. And so making sure that we're managing that. Biliary atresia. So it's also called extrahepatic biliary atresia. It can appear healthy. They can appear healthy at birth, and then suddenly the jaundice persists. One of the signs can be that dark Coca-Cola colored urine, and the stools can also be progressively like gray or clay colored, indicating like an absence of the bile pigment. And so I've seen this actually with we had a baby in the nursery who had been there maybe about 3 or 4 days and was just passing meconium originally, and then about 3 days in started having clay stools. And so definitely a concern. So we transferred him out. And so if it's untreated, it can result in cirrhosis. So you'll learn more about liver cirrhosis in term 4, but biliary atresia can turn into liver cirrhosis. And so it's just good to always know like the signs and symptoms of somebody who is having hepatotoxicity, hepatitis, inflammation of we'll call it inflammation of their liver, issues with their liver, the Coca-Cola colored urine, the gray or clay colored stools, the jaundice, the nausea, that kind of stuff. Okay. And then esophageal atresia and tracheoesophageal fistula. So esophageal atresia and tracheoesophageal fistula, we talked about this when we talked about newborn assessment. So this was the one where if they had like the excessive salivation, drooling, or right after they nurse or have a bottle, they're choking, they're coughing, right? So, or they have like an apneic episode or respiratory stress right after eating. So what it's telling us is that they are not able to swallow down everything that they just took in, and we'll see the pictures of it in a second. So you can see this is our normal anatomy. We have our trachea, we have our esophagus, and then our atresia. So this is where we have complete atresia of our esophagus. It does not go down at all into our stomach. Our trachea actually does. Oh, I don't have the pointer on. Okay, so we have complete atresia. Over here we have atresia with a fistula. So there is a pathway down. And so you can see how it's going to depend on just, is it going down to their stomach? Is it completely cut off like this one? How extensive the signs and symptoms are. But you can imagine why that would immediately have an effect on their respiratory system, right? Definitely. Okay. So afterwards, they can have special issues, special problems, what they said. They're at a high risk for infection, especially upper respiratory infections, okay, after they've had it fixed. And then they also are at a risk for leaks, so monitoring to see if they have any respiratory stress, being very careful about feeding them and reintroducing that would definitely be a concern. Cleft lip and palate. So we've talked a little bit about this, but you see they can have either a cleft lip and no cleft palate, or they can have a cleft palate and no cleft lip, or they can have a cleft lip and cleft palate. They can have a cleft palate where it's in the hard part of the palate or in the soft part of the palate. Okay, so all of that really depends on how well are they going to eat. You know, when you have the cleft lip, that's going to have a much harder time getting that good suction on a bottle or breastfeeding. When you have the cleft palate, you definitely have a risk as well of going up into the respiratory system and some issues with suction. So the cleft lip, cleft palate definitely has some of the harder times with feeding. So what do we do? So of course, surgery is going to be the goal, but oftentimes it's not going to be done until later in life. They don't necessarily do it as soon as they're born. So 2 to 3 months is when they're starting to evaluate them for and plan it all out. Okay, so until then, they're going to do different feeding mechanisms. So they can use special nipples, orthodontic nipples. They can do cheek massage to kind of help with that suction. They'd want to do upright positioning, so that way you have a less risk of it going into the respiratory system as well, because they're at a big risk for aspiration. Anorectal malformations, we're going to have a picture in just a second. It all depends on just how bad it is. So you can see when you have the colon, vagina, and urethra all going to the same hole. And then you have the other one where right here where you have our vagina and colon going to the same hole. And then for the male, the colon and bladder going to the same hole. That would be probably one of the worst issues that you could have. So definitely would need to be fixed. So other words for it can be imperforate anus. So when you do not have a full anus. So, okay. What type of dehydration is defined as dehydration that occurs in conditions in which electrolyte and water deficits are present in approximately balanced proportion? Remember, when it's balanced, what is it? Isotonic. Yes. Good job. Okay, we're going to do a little next gen style. So we have a 12-year-old female who's admitted to the pediatric intensive care unit post-operatively. The child had a ruptured appendix, which required an open appendectomy. During the procedure, she became hypotensive, and dopamine was required to maintain her systolic blood pressure. Her blood pressure continues to be low. Upon admission to the PICU, she had a heart rate of 82, temp of 100.9, pulse ox is 99%, 16 respiratory rate. Her arterial blood pressure is 72/46. Her intake and output, she's intake is 2055 and output is 240 milliliters. Okay. Her MR, so she's got dopamine, currently infusing. She's got normal saline, piperacillin, tazobactam, and morphine for pain. She is alert. Pain is 8 out of 10. Respiratories are clear upon auscultation, less than 3 seconds for a cap refill, plus 2 extremity pulses. Abdomen soft, tender to palpation. Incision dressing is dry and intact. Glucose, good to go. Potassium, good to go. Sodium, a little on the low side, but overall not bad. Hemoglobin, a little on the low side. Hematocrit, yeah. White blood cell count, woo, that's high. Okay, so what nursing action is done to prevent each potential complication? So a deep vein thrombosis, well, let's see. So what would get rid of a deep vein from thrombosis? I know the answers are right there, but we're going to talk about it anyways. So what would get rid of a deep vein thrombosis? So our sequential compression devices would definitely help with that. Our bleeding or abscess, so monitoring those lab values. Now, she was on the cusp for H&H, but she did just have surgery, so maybe not our indication right there, but definitely something that we would watch. Those white blood cell count, that was pretty high, but we also know that she just was admitted for an infection for appendicitis, which is inflammation at least. So we're expecting it to be high. We're not super surprised, but we're definitely going to watch it and hope it comes down because we're giving her their antibiotics. So peritonitis, we're going to be giving her those antibiotics and hoping it improves. And then fluid and electrolyte imbalance, so we're administering her IV fluids. Okay, another one. So we have parents of a 6-week-old bring him to the emergency room after 3 days of nonstop projectile vomiting. The mother states that the infant has had projectile vomiting every feed. Heart rate is 170, respiratories are 32, blood pressure is 80/44, gap refills 2 to 3 seconds, extremity pulses are 4+, fontanelles are flat. Okay, so we are going to go through whether something is indicated, contraindicated, or non-essential. Okay, so I'm going to just take a pause with my talking, and I'm going to have you guys look at those questions. So would you want to give normal saline? Would you want to administer a gas enema? Would you want to administer keep the child in PO? Would you want to monitor intake and output? Would you want to educate parents regarding the incision site care? Okay, so with kids with pyloric stenosis, they are at risk for metabolic alkalosis because they have this depletion of the hydrogen and electrolytes from excessive vomiting. So we would not want to give them normal saline. It's not going to improve the remaining electrolytes, and they'll actually continue to have the electrolyte imbalance rather than fixing it. So fluids with both electrolytes and glucose should be administered, like a D5 half normal saline with potassium would be best. And a gas enema is what we do for intussusception, not pyloric stenosis, and that may further damage to the GI tract if it's administered, so we're not going to do that. The intake and output should be strictly monitored. So we are going to keep the child in PO due to the likelihood of so we'll keep the child in PO due to the likelihood of furthering dehydration and metabolic alkalosis. So we're going to be managing it parenterally, right, with those extra electrolytes in our fluids. And then educating parents about the incision site. So it's important, but it's not essential right now. At this point in time, we're just going to be talking to them about the impending surgery itself. Okay, we're not going to be educating them on what they're going to do when they get home. Okay, I think that was it. That's all I got. So I'm going to give this to you guys and hope that you guys can watch it before we do our review on Wednesday. Thank you.